Hi, and welcome to Chapter 14, finishing up thalassemia, phenotyping, and clinical presentation. So in slide 2, we see the alpha thalassemia genetics and clinical consequences. So we know that thalassemia is an inherited hemoglobinopathy or problem with the hemoglobin characterized by the impaired synthesis of the alpha globin chains, leading to a variable clinical picture now depending on the number of affected alleles. So here we know we have two normal alpha chains from mom and dad in the first image here. As you see, with carrier states, we can have one affected allele, and usually in this state there's no abnormalities. The patient is completely healthy and asymptomatic. But as more of the alpha chains are affected, you start to see some kind of mild microcytic types of anemias. And again, they're classified based on their increasing severity. So as we see the third slide down, hemoglobin H disease, we have 3 mutations or deletions of the alpha chain, leading to hemolytic and microcytic anemia. And these hemoglobin H, as you saw in the overview slide, this is a tetramer of 4 beta chains, creating an abnormal hemoglobin. Now, the most severe, if you have no alpha chains, it's completely incompatible with life, called hydrops fetalis. Usually infants don't make it to term in gestation or not much further past birth. So in slide 3, table 14.4, lists the characteristics of alpha thalassemia. So we are going to learn about how to genotype and phenotype these types of conditions. So the first genotype you see here is the most severe type of alpha thalassemia. So we're talking about the genetics of the alpha chains. So when they have an alpha 0, that means that there are no alpha chains from mom and no alpha chains from dad. So the genotype are dashes, meaning that there are no alpha chains present. So the description would be homozygous alpha thalassemia 1, leading to a hydrops fetalis, which is the name of the phenotype or the disease that physicians usually call the severity of the thalassemia. Now the findings here, you're going to have a marked anemia, microcytic hypochromic environment right away at birth if you get a peripheral smear. Again, this is fatal. You have no alpha chains. So the other alpha or hemoglobins that could be present would be hemoglobin Bart's, which is the abnormal gamma chains there because this is at birth. And again, Portland is just the abnormal epsilons that is an embryonic hemoglobin, creating the other types of hemoglobin present. The second genotype, we have an alpha 0, meaning there's no alpha chains from mom or dad, and then consequently other parent does have one alpha chain. So this is termed as a heterozygous type of alpha thalassemia, leading to hemoglobin H disease. So out of the 4 alpha chains you could have, this patient only has 1 genetically. And again, this is a moderate to marked anemia. You're going to find a lot of things in the peripheral smear leading towards more abnormal red cell morphology. And here you have a chronic, severe hemolytic anemia. Patients need chronic transfusions through their life. And the most common significant finding here with hemoglobin on electrophoresis, so all of these hemoglobins present are going to be detected upon hemoglobin electrophoresis as a reflexive test, would be hemoglobin Bart's at birth, again that's 4 gamma chains, and as an adult or after 6 months to a year, you're going to start to see hemoglobin H, which is a tetramer of 4 beta chains. The next one is a genotype with one parent not having any alpha chains and the second parent being normal with their alpha chains. So again, a heterozygous type of genotypic description, and this is considered alpha thal minor because the body's compensation to create some sort of hemoglobin A will be present. So the compensating mechanism is there. Again, you still have some excess beta chains, so you can still have hemoglobin BARTs at birth. You may or may not have a slight hemoglobin H and a slight type of anemia, mild to moderate. The fourth genotype down is one parent is missing either of the alpha chains, leading to a homozygous alpha thal. And again, this is a minor type of alpha thalassemia causing slight anemia, and you'll see that the hemoglobins can compensate, but you might still see some peripheral smear abnormalities there. The last type is the silent carrier type of alpha thalassemia, where there is only one missing or deleted chain, and here you really don't have any type of anemia. Everything seems normal. You might have a slightly mild anemia, but usually the patient is very compensating in their presentation. Clinically, it's very hard to find images of alpha thal major or hydrops fetalis because this is a severe microcytic anemia, and usually these infants don't live much past birth due to the lack of complete alpha chains. So I'm going to show you an image here of the hemoglobin H disease where patients are symptomatic, but it is a non-fatal type of thalassemia where 3 of the 4 genes are deleted. And here you would definitely see a microcyte hypochromic environment. Look at these cells. The hypochromasia is marked. And I'm putting in a lymphocyte for you so you can have a comparison. And definitely, because of this hemoglobin problem, you're going to be seeing a lot of target cells, which is definitely a image of hemoglobin H disease. So here you will see a supravital stain using brilliant crescent blue to precipitate that unstable hemoglobin that you're seeing in the cells that have, it looks like a stippling. Okay, this type of hemoglobin H has an increased affinity to oxygen, which reduces the delivery of oxygen to tissues, causing it to be unstable and precipitate within the cell. So here you'll see a lot of hemolysis. With that, your spleen will be enlarged, so will your liver, and you won't see a lot of skeletal or facial changes like you do in beta thalassemia because the erythropoiesis is only a little bit affected. You might also see on the hemoglobin H peripheral smears reticulocytes and possibly nucleated red blood cells due to the hemolysis. So here is a peripheral smear picture from a patient with alpha thal trait, where here you have a decrease in the alpha containing hemoglobins, but it is unaffected as the body's able to compensate to greater than normal degree for the deleted genes. So with the clinical findings, you may see a mild anemia. They may not be symptomatic at all. You might see a few target cells and possibly a slight microcytosis. For treatment of these patients, usually if they're asymptomatic, they lead a normal life and they don't need any kind of medical intervention. Now let's talk about beta thalassemia. So here we know that there are two beta globin genes located on chromosome 11, one from mom, one from dad. So the deletions are a little bit different, and the genotyping and phenotyping is a little bit different than alpha thalassemia, because a lot of the times the mutations here are non-deletional, so there could be a partial block in the beta chain synthesis. So if there's a partial block, you'll see that there will be the beta and the plus, where the beta with the 0 is a complete absence of the beta chain. As we saw in the alpha thalassemias, it's going to be designated as a 0. So we have different categories here. So you'll see in the top you have B and B, that's one normal beta chain inherited from mom and dad. So there is no type of expression phenotypically. Underneath that, you'll see a beta thalassemia trait, where you can have either one inherited complete deletion or absence of the beta chain, or a partial block in the beta chain synthesis causing a beta thalassemia trait. Now here, this is classified as minor. Sometimes you might have a microcytic hypochromic type of anemia, but it will be mild as the body can compensate as you have one normal beta chain. Now when you get into the beta thalassemia intermedia, this is where either you have a partial block or a complete absence of the chain. And here you might have variable severity causing a mild to moderate type of anemia. You might have other places besides the bone marrow making the cells, and if you happen to have constant transfusion here, you might get iron overload. The last and most major beta thalassemia major, or another name, Cooley's anemia, is the major type, and you have a complete lack of the beta chains here, causing a severe type of anemia and lifelong transfusion dependency. So with that, we need to know, not create medically induced iron overload, so they need to chelate some of that iron. And again, you'll have an enlarged spleen, enlarged liver, because your body's trying to make more normal cells. Now in the overview, because there was a lack of beta chains, you do have an excess of alpha chains. However, alpha chains cannot come together as they are very, very unstable. So you will never have a tetramer of four alpha chains coming together. Now here is an image of beta thalassemia major. Okay, so here we start to see clinical manifestations at about 6 months of age when the hemoglobin starts to convert to A. So as you can see in this image, the increased erythropoiesis of the bone marrow to extramedullary places causes expansion of the cavities and creates, if you can see at the top, it looks like hair-like projections on the skull of a boy. So the expansion causes thinning and calcified bones, and in this next image you'll actually see the deformities that beta thalassemia major patients can have. Now here, after about 6 months of age, parents are definitely going to sense a type of symptoms. Definitely as infants, they'll see a lot of diarrhea, fever, enlarged abdomen, and pallor, failure to thrive here, severe type of anemia, could even cause cardiac failure. The skin of these patients sometimes take on a bronze pigmentation, as you can see here, and you can see the bone changes of this little girl. There's bossing of the skull and facial deformities. And we saw in the last radiographic image, if they took a skull radiograph, you can see the hair on end projections. And again, this poor little girl probably has an enlarged spleen and liver. So here is the peripheral smear of a patient with beta thalassemia major, where hemoglobins can drop to as low as 2 to 3 grams per deciliter. Definitely a microcytic hypochromic type of anemia where the MCV can be as low as in the 60s. The peripheral smear here, you're seeing that there is a great variation of aniso and poikilocytosis. Other things you might see, some basophilic stippling. You might see polychromasia due to the bone marrow trying to compensate, and nucleated red blood cells, as you can see in the top right corner there. And again, a lymphocyte for you to see the comparison of the sizes. Now, for treatment of these patients, they're going to have regular transfusions to try to minimize that anemia, and maybe some iron chelating agents. And if the hemolysis is so bad and the spleen is very enlarged, they might actually remove the splenectomy depending on if they can. Sometimes they do bone marrow transplants with suitable donors. And at this point right now, stem cell therapies or transplants are very controversial. So the prognosis for untreated beta thal major children or patients can die within the first or second decade. But there has been some definite gene therapies and drugs and transfusion support to help slow that progress here. So again, I always have to say we are so lucky in North America to have all these treatments available to us. Now here is an image peripheral smear of a patient, beta thal patient with minor genotype or phenotype. Lab results will definitely show a mild microcytic hypochromic anemia ranging anywhere from a 9 to 14 gram per deciliter hemoglobin. And the MCV can be slightly lower. Okay, these are minimal morphological abnormalities. Now, variable in the peripheral smear, you could see target cells, basophilic stippling, sometimes a little bit of an increase in your reticulocytes, so polychromasia. And here in the hemoglobin electrophoresis, you might see a slight increase in hemoglobin A2 and F. Now, there is definitely also other types of thalassemias and thalassemia-like conditions that involve globin chains other than the alpha and beta. Sometimes they can be combined as well with more than one globin chain, or in combination with a hemoglobinopathy as well. So in this kind of image I'm showing you, here is a patient with hemoglobin Lepore, which is a non-alpha chain. It's a beta and delta globin hybrid. It's caused by the unequal crossover during meiosis and kind of forms a fusion gene, and a lot of the times this is seen on your board exams here, so I'm listing it here as a delta beta gene fusion. It combines with alpha chains to form hemoglobin Lepore. The pathophysiology of this is similar to the beta thalassemia and can be classified as either major or intermediate. Here we'll see an excess of the alpha chains, but you're going to have a decrease in hemoglobin A, and you're going to definitely have an ineffective erythropoiesis, and you'll see a lot of extravascular hemolysis. Now, if it's heterozygous, you might be asymptomatic, classifying you in a minor category. And here on hemoglobin electrophoresis, you will usually, or most likely in the homozygous states, no hemoglobin A or A2, but the hemoglobin Lepore abnormal hemoglobin will be 8 to 30%, and the remainder will be hemoglobin F, that you will see, and you'll see in this picture here that you have a microcytic hypochromic type of anemia. In the heterozygous states, you'll see that hemoglobin Lepore is only about 10%, where you still have some hemoglobin A made and normal amounts of hemoglobin A2 and F. Now, for treatment of these cases, severely anemic cases require a transfusion protocol. Now, here's a patient with a peripheral blood smear of a combined disorder. Usually it's double heterozygous because you have a hemoglobinopathy as a structural variant with a thalassemia. So here you have hemoglobin S and alpha thalassemia. So these cells next to that lymphocyte you can see that there's definite microcytes there. You can also see some acanthocytes in this picture. And one last combination image for you on a patient with a hemoglobinopathy and thalassemia. Here we have hemoglobin E with an alpha thalassemia combination. Now you can see definite microcytic hyperchromic environment with marked target cells present.